Yes, we are live. We are live.
Okay.
We were muted. Just let me turn this on 1 second. Sorry.
All right, I think we can start now because it's 7:30. Okay. All right, good morning, everyone. This is Dr. Haresh Sampath Kumar, co-founder of JH Rehabilitation. Today is day 4th of our webinar series on Post ICU rehabilitation as it relates to COVID-19. Today, we have a couple of speech-language pathologists to give a talk on this topic. So I'm going to introduce both of them in the order that they're going to give the talk. So first, we have Beth Cross. She's a senior clinical specialist in speech-language pathology at Mount Sinai Hospital in New York City. She has 15 years of experience, primarily diagnosing and treating dysphagia in the acute care setting. She treats patients across the lifespan with dysphagia of various etiologies, such as prematurity, cardiac disease, post-extubation, tracheostomies and ventilators, CVA, head and neck cancer, and neurogenic diseases. So she has a wide range of exposure. So the next speaker is Dana Spivak-David. She is also a senior clinical speech-language pathologist at Mount Sinai Hospital in New York City. She has over 25 years of experience working in acute rehabilitation setting. Her expertise is in various neurological deficits such as CVA, TBI, spinal cord injury. She also focuses on assessing and treating patients with dysphagia, cognitive linguistic deficits, aphasia, dysarthria, and apraxia. She has also worked extensively with tracheostomized patients and ventilator-dependent patients. Both Dana and Beth are part of the ICU rehabilitation team at Mount Sinai Hospital in New York City. As most of you know, that New York City is the epicenter of the coronavirus outbreak, and certainly their expertise and exposure to COVID-19 will bring us a huge value. So without further ado, I would like to have Beth proceed with the talk for today. Thank you, Beth.
Hey, everyone. Let me just bring up my slides here. Which one is it? This one?
Yeah, you can share screen.
Oh.
Yeah.
Look at that.
You can put it in presentation. Yeah, perfect.
Perfect. Okay, so we're going to talk about swallowing cognitive and speech and language considerations for patients with COVID-19. So one of the biggest challenges that we have in managing these COVID-19 patients is that there's very limited research. Anyone who claims to be an expert on COVID particularly is not an expert. This virus, we didn't know about it 4 months ago, so I don't know that anybody can be an expert. I thought that quote was very relevant from Dr. Angela Rasmussen. Sorry, is there a way for me to move the images where I can, you and me, because they're blocking the slides?
You have an option,
Oh, to reduce,
right?
I think I can reduce
Yeah,
it. Okay,
to reduce it up.
thank you.
You get it?
Okay, yes.
Yeah.
One of the most difficult aspects about COVID-19 management is that everything is new. We don't have significant research to guide our decision-making and clinical practice. So for that reason, our clinical decision-making has been fluid. We're constantly adapting as we learn new information and as medical management for COVID patients evolves. So I'm going to talk to you a little bit about the timeline for how things rolled out here, because we're making decisions as things are coming up. The first thing that happened was we had reduced access to objective assessments, and this was before we ever even had our first dysphagia consult for a COVID patient. So on March 16th, the radiology department contacted us and said we needed to limit access to modified barium swallow studies to the general public as a precautionary measure for the radiologist and for the speech-language pathologist to prevent accidental exposure. This was even before we were doing full-on masking all the time. So we just wanted to be absolutely certain that no one was getting an exposure, and no COVID positive patients obviously would be allowed. So we had to figure out which population was the most important that we would allow them immediate access to MBS. So we determined if a patient was NPO and we were having trouble upgrading them to a diet, they would be allowed to go down. Trach patients were an automatic go for MBS, and head and neck patients. All other patients we could consider on a case-by-case basis. Otherwise, we were deferring everything to fees. Seemed like it was going to be a good plan. And then on March 20th, Stanford University ENT Town Hall began circulating with individual experiences out of Wuhan, suggesting that the nasopharynx carries the highest viral load. So clinicians performing procedures of the nasopharynx were reporting widespread infection and higher death rates. Once we received that information, on March 20th, we shut down fees effective immediately on all patients. Moving forward without access to fees or MBS, we needed to streamline our decision-making at the bedside throughout the SLP department. So we turned to one of the protocols that we use that's actually a very strong alternative and to help us with our decision-making, the Yale 3-ounce water screen. Currently, every single patient in all of our ICUs who's post-extubation gets a Yale 3-ounce water screen to determine if they are appropriate for an SLP consult. So let's look at that screen a little bit more closely. We're going to review just first the validation. So the initial 3-ounce water test was performed in 1992 on 44 stroke patients by DePippo. And then later in 2008, it was revised and it was administered to 3,000 patients with 14 distinct diagnoses. The initial one had been normed with an MBS and this one was with a FEES. So this screen correctly predicted aspiration 96.5% of the time. So if a patient failed 96.5% of the time on the FEES, they were aspirating, and a negative predictive value of 97.9%. So if they passed 97.9% of the time, they were not aspirating on FEES. So that's a pretty good screen. And the screen was normed on patients who had diagnoses such as esophageal surgery, head and neck cancer, neurosurgery, other medical issues or neurological issues such as CVA, multiple sclerosis, TBI. So it really reached a very wide range of patients. So the first step that we always teach the nurses who are doing the screen is that there's exclusionary criteria that would prevent a patient from being able to participate. If they're unable to remain alert for testing, if they were already on an existing modified diet prior to this acute event, if they had an existing feeding tube, either NG or G tube prior to this acute event, if they're unable to raise their head of bed above 30 degrees, if there's a tracheostomy tube present, or if they were NPO for any reason other than this pending SLP eval. For all those reasons, it would be a hard stop and they would do a dysphagia consult to SLP. Assuming the patient is able to pass all of those criteria, then we go on to the administration. So we want them to drink 3 ounces of water, sitting upright 80 to 90 degrees or as high as tolerated, but it has to be higher than 30. And the patient has to drink the entire 3 ounces of water from a cup, sequential swallows. Doesn't need to be fast, but they can't take a break. If the patient does take a break, or if they're coughing, choking, throat clearing, wet hoarse vocal quality, all the signs we would normally look for within 1 minute after drinking, then that would be a fail. And the reason why we need them to drink the whole 3 ounces is because for patients who are silently aspirating and they might not feel the water, if they're drinking a high enough volume, the theory is that it would travel far enough down into the trachea that it would trigger a response. So if the patient's able to complete this uninterrupted drinking of all 3 ounces and they don't show any signs of aspiration, then it's a pass, and the nurse and doctor are okay to upgrade the diet. They can do thin liquids, and they can choose a texture based on what the patient's dentition is. And then the RN will continue to monitor, and if any new concerns arise, they can always reach out to SLP. If the patient is unable to drink the 3 ounces or they show signs of aspiration, then they've failed. They have to remain NPO, including medications, and request an SLP consult. However, if prior to the SLP consult, the patient appears to have changed, let's say 2 hours have gone by and the patient's more alert and they look better, the nurse can always re-administer the protocol and DC the SLP consults if it's no longer required. So initially, when we started getting our first COVID-19 patients, they were few and far between, the consults, and we were managing them through telephone and video calls. So we would get a consult, we would do a chart review, communicate with the nurse and the doctor about the level of alertness. And a lot of the times we would do telephone in-services to the nurses who were not coming from the ICUs and were not familiar with the 3-ounce water screen on how to use it to determine if they really should consult speech therapy. And when possible, and in the beginning it was possible often, we were doing video assessments with the help of a PCA who was in the room, because a lot of these patients are confused. We'll get more to that later. So there was they had one-to-ones, and we would use a screen, we would watch them eat, and we would see if there was anything that required us to go into the room or if we could make recommendations. As time went on, it wasn't possible to manage it that way. And we also started noticing trends that most COVID-19 dysphagia consults involved supplemental oxygen use without any short-term ability to wean. So we needed to figure out how to manage these patients despite their supplemental oxygen. So I'm going to review what these different supplemental oxygen sources that we were seeing are. This might be familiar to some of you, but let's just review all these different types. The first one is bilevel positive airway pressure. So this machine helps push positive air pressure into the lungs. It's connected to a ventilator and a mask is placed over the face. It opens the lungs with positive air pressure. The air pressure keeps the pharyngeal muscles from collapsing and reducing obstructions by acting as a splint. So even during non-COVID times, we don't feed these patients if they're primarily on BiPAP. And a lot of the questions that we get from the doctor, what if we can take them off for 10 minutes? Because of the way it's splinting the airway open, as soon as we put the mask back on, it places them at a very high risk for vomiting and then aspiration of that vomit. So we do not do swallowing consults in general on patients who need BiPAP for the majority of the day. And overnight BiPAP is a separate issue. So for now, we're saying that this patient is not appropriate for a dysphagia consult. Then we have a non-rebreather. This is a mask. It's placed over the nose and mouth, connected to a reservoir bag that's connected to oxygen. A one-way valve prevents exhaled air from re-entering the reservoir. Exhaled air escapes from valves on the sides of the mask. This can supply more oxygen than a regular nasal cannula, which we'll show in a couple slides. This one can do 10 to 15 liters per minute. And we're actually seeing these a lot more often now in the time of COVID-19 because the patients, many of them are ventilating well, but they have hypoxia. So this is a good solution for them. Is this patient appropriate for a dysphagia consult? The liters are relatively low, so we're not really concerned about the airway from the oxygen delivery, but the patient can't access their mouth without desaturating. So what are we supposed to do with this patient? We'll get back to this later. Then we have high flow nasal cannula. Warmed humidified oxygen is delivered via thicker nasal cannula prongs, which occlude the nasal passages. It has a maximum flow rate of 60 liters per minute and a maximum FiO2 of 100%. High flow rates of O2 wash out the nasopharynx and upper airways with delivered O2, creating oxygen reservoir and reducing CO2 rebreathing. The higher flow rates match inspiratory flow rates in patients with increased work of breathing and minute ventilation. Is this patient appropriate for a dysphagia consult? So normally we would see these patients at the bedside, regardless of what their flow rate is, because their flow rates were not actually that high up prior to COVID. I think the highest we would actually see them was around 60, I'm sorry, around 50. And we would almost always use a fees on this patient, but we can't do fees on these patients, and we're not allowed to bring them down to MBS because of COVID positive. So we wanted to look back into what the research says about the aspiration risk on this, but there's two ethical dilemmas with completing research on these patients. But here are the two things that we do know. Park et al. In 2006 wrote that peak pharyngeal airway pressure at 35 liters per minute was around 4 to 5 centimeters of water pressure, which is CPAP pressure. And according to James Coyle, 100% of the pressure from high flow nasal cannula is delivered to the pharynx during the swallow since the patient's mouth is closed. So whatever pressure they're getting is going to be getting in the way while they're drinking or eating. So like BiPAP, high flow nasal cannula also presents a risk of splinting the airway open, especially at higher liters and especially during the swallow. So we're going to come back to this one in a bit also. This one, the low flow nasal cannula, and this is probably the most common in normal times, delivers 100% FiO2 given at designated flow rates, ideally between 2 and 6 liters per minute. I have seen it set to different settings, but if it's a higher flow rate, it's drying the nasal mucosa. And if it's a lower flow rate, there's a failure to create a nasopharyngeal reservoir. And a lot of people will tell you that this really doesn't change the breathing at all. Like you can slap 2 liters of nasal cannula on anyone and it's the same as, you know, their swallow doesn't change at all. There's no external reservoir. Nasopharynx acts as an anatomic reservoir. O2 inspired from the nasal cannula mixed with ambient air and trained from around the device. So this patient is definitely appropriate for a dysphagia consult. There's no impact on the airway that we are aware of. All right, this is the last one. We actually were not seeing trach patients in the beginning, but we'll get to that in a second. So this is a trach collar with or without oxygen mask. It's a surgical airway created to facilitate weaning from the vent when patient has had prolonged intubation. So prior to COVID-19, we had a policy at the Mount Sinai Hospital where patients by and large were trached by day 12. Initially with COVID-19 patients, we were being told that we weren't going to trach them because it aerosolizes the virus and it places all the providers at greater risk. And even, you know, a lot of the webinars that we were watching were saying we weren't expecting to have to manage this population in COVID. But, you know, things change as we were saying before. And currently we are seeing a lot of COVID-19 patients with tracheostomies. Primarily, these are patients with good rehab potential if we could wean them from the vent. So we're proceeding with trachs. So here are some very important considerations with this population, irrespective to COVID. They have reduced airflow in the nasopharynx, which leads to reduced sensation and increased risk for silent aspiration, up to 50%. So up to 50% of the time, if they are aspirating, we will have no signs at the bedside. And remember, the 3-ounce water screen has not been normed on this population. The presence of a trach is one of the exclusionary criteria, so we can't even rely on one of our most useful tools in the absence of objective assessment. We used to use green dye on these patients many years ago, but 50% of tracheostomized patients with known aspiration on MBS were negative when using the blue dye screening. So it's not really such an effective tool. So this patient can be appropriate for dysphagia consult, but it's typically managed with an objective assessment via MBS or fees. So what are we supposed to do with them right now? So we took all of this information and put it into a decision tree. Should I consult this the SLP for dysphagia for COVID-19? So as you can see, the first thing we had to rule out was if they were alert. It sounds pretty intuitive, but you know, so many of these patients are confused, and as soon as they're extubated, we're getting consults. So we have to rule that out right from the get-go. Once we've determined that they're alert, we've broken it down into the different types of oxygen that the patient might be on. So again, room air and low flow nasal cannula, they can proceed directly to the 3-ounce water screen. BiPAP and ventilator are hard stop. Ventilator would not automatically be a hard stop during non-COVID times. However, assuming that they are trach to vent, but we have no way of assessing them, and their risk for aspiration is so high that we need to wait until they wean a little bit more with COVID specifically. Trach collar, I'll talk about how we're managing it a little bit in the following slides, but that's a consult to SLP. We don't want the team doing anything at the bedside because they can't do anything at the bedside. We can't tell them about the 3-ounce for those patients. And what we decided for the other populations, for non-rebreather, if they can tolerate taking the mask off for at least 1 hour and not desaturating, and they can use nasal cannula during that time, then the non-rebreather, then those patients can eat food even with the non-rebreather, because if you put the non-rebreather back on, you're not worried like BiPAP with the issue of vomiting and aspiration. So those patients can proceed with a 3 ounce and then a dysphagia consult if necessary. On the high flow nasal cannula, we set the settings at a maximum of 40 liters per minute and an FiO2 of 50%. And we're a little bit more flexible with the FiO2 than with the liters per minute, because remember, the liters per minute is what's splinting the airway open. But if they have those settings, they can proceed with a 3 ounce and then consult SLP if necessary from there. So here's our challenge. How do we manage the COVID positive patients who are appropriate for dysphagia consults, but are heightened risk for silent aspiration? So I'm specifically thinking about the high flow nasal cannula patients and the trach patients. What are we supposed to do with them? So when we assess the high flow nasal cannula patients at the bedside, we make sure to push really high volumes of PO trials. Like, it's 3 ounces what our norm is, but we're pushing sometimes 8, 12 ounces at the bedside just to really see if they're going to show any sort of overt aspiration if they seem fine. We monitor closely for those overt signs, tachypnea, change in oxygen, change in color, patient reporting any discomfort or increased work of breathing. And then if we do initiate a diet, we provide frequent check-ins, make sure to circle back and talk to the team, really be involved in the follow-up on these patients and educate the provider on what to look for at the bedside, which is all the indications above, as well as monitoring the chest x-ray for any concerns. Moving on to the trach patients, we're starting to focus a lot. We already were using speaking valves, but being very careful to try and make sure that they're used prior to swallowing whenever possible. So many of you are probably familiar with the Passy-Muir speaking valve. The one on the right is the purple valve is the one that we place on the hub of the trach for trach collar patients. And the one on the left you can use similarly for trach collar patients, but it's also designed to be used for inline with the vent, which we would use during normal times, but during COVID-19, we are not using those to be inline. So when we go to the bedside to see the trach patients, skipped ahead of myself. Benefits of the speaking valve use. Research studies have found that patients with an occluded or closed system have improved airway protection and aspirate less than those with an open system. It restores positive airway pressure, and this facilitates the patient's ability to generate protective cough, which improves airway protection during the swallow. It allows for a patient to voice, and this can be a helpful tool when we're trying to assess them at the bedside so we can hear their vocal quality. And the use of the speaking valve facilitates the decannulation process, and they're often used prior to capping. So how are we actually managing these patients when we go into the room if they're trach and COVID-19 positive? We do a lot of education and advocacy for downsizing the trach size. We're very often getting consults on patients immediately post-extubation. And during intubation, these patients have a size 8 Shiley so that it can work with the vent. But post-extubation, it would be better for their swallow if we could downsize the trach. Then we work a lot on speaking valve use. Digital occlusion when not tolerated, but preferably speaking valve use. And a big part of COVID-19 trach management is training the patient on donning and doffing independently, because the nurses are clustering their care to prevent over PPE use, because we need to protect that. So there's not someone in the room every 5 minutes like there might be during normal time. And remember, these patients are not allowed to have visitors, so they don't have someone sitting there who can help do it for them. So we want to make sure they're alert and capable of taking it on and off by themselves. And then we'll give some PO trials at the bedside. And this is kind of the way that this is managed is mixed amongst the clinicians. Some people will trial a lot of one consistency and really push a lot of water, like I said, with the high flow. Some people are trying multiple consistencies. Some clinicians are trying a little bit of green dye, because even though it's not a strong tool, the one instance where it can be helpful is if there's immediate aspiration, then we're pretty sure that that's a positive. We don't know why it happened because we can't see inside, but we know that there's an increased risk. And other people are just doing some ice chip trials without and taking it from there. But we wanted to figure out candidacy for MBS in this population because there's such a high risk for aspiration. And we noticed that many of the trach patients who have dysphagia consults have been intubated for 2 to 3 weeks. So this means that they're typically approaching COVID negative status. If patients seem like a strong candidate to initiate PO, then we start discussing the possibility of a COVID-19 swab with the team. And if they can be deemed negative, then they can go to radiology for an MBS. So what does it mean to be deemed negative? They have to have 2 negative swabs The swabs have to occur at least 24 hours apart. And then when we bring them down to MBS, just as an abundance of precaution, we continue to use the PPE protocol as if they are COVID positive while they're in the MBS suite. Because again, the MBS suite is not a negative pressure room. Okay, I'm going to hand off to Dana. Oops, sorry.
One second. Okay, so Beth gave a great summary of how we handle dysphasic patients. And so I kind of wanted to go on and explain about what else we can do for the speech, what the speech pathologists can do to facilitate rehab in these COVID-19 patients. So additionally, we take a look at their cognition, their language, as well as motor speech disorders such as dysarthria, apraxia, respiratory issues, and voice. So I wanted to kind of go over some of the latest research. And again, this is all coming out new, so things are changing all the time. But according to a research letter published in the New England Journal of Medicine, a study conducted from March 3rd to April 3rd, 2020 of COVID-19 patients in the ICU from France with an average age of 63. 1/3 of these patients were found to have problems with executive functioning. So that means their memory, their attention, mental flexibility, as well as possibly higher level reasoning and organization. So they found that these patients were disoriented and also had difficulty following directions. Additionally, in the New Yorker, an article published on April 23rd called Challenges of Post-COVID-19 Care by Dr. Kuhler, he noted that the patients with prolonged intubation are profoundly debilitated. They experience weakness, memory loss, anxiety, depression, and hallucinations, and also have difficulty sleeping, walking, and talking. And in the same article, Dr. Kuhler reported of a 2013 study of discharged intubated ICU patients from the New England Journal of Medicine that said 3 months after leaving the ICU, 40% of these patients had cognitive scores that equaled a moderate traumatic brain injury. So the takeaway from these sort of research studies and articles are basically that these COVID-19 patients have severe cognitive deficits. They definitely have cognitive deficits. And it's also something that's not going to go away immediately. It's going to be months of rehab that they're going to have to do to get past this. And obviously need speech therapists to help with that. So also Dr. Kuhler reported that patients will need pulmonary rehab and will learn breathing techniques and get help with gadgets they can use to clear mucus from the lungs. Some will be shown how to cough better. So that makes sense with all the respiratory issues that they're having that Beth sort of went over. This is definitely something that's going to be also a long-term process to get better, to work on the respiration. And then also you can surmise that these patients are being intubated, so they really have a potential to have some type of vocal fold injury, possibly related to intubation. So something also to consider as a speech therapist. Also, we're finding now that these COVID-19 patients are having strokes. In the New England Journal of Medicine, an article called Large Vessel Stroke as a Presenting Feature of COVID-19 in the Young by Dr. Oxley, a neurologist from Mount Sinai, Beth Israel, he noted 5 patients ranging from the ages of 33 to 49 with COVID-19 had blood clots that resulted in strokes. In another article that was on cbsnews.com on April 29th, Coronavirus Linked to Strokes in Younger Adults by Dennis Thompson, he noted 2 hospitals, Thomas Jefferson University and NYU, reported COVID-related strokes, noting that 12 of their patients with clot-caused strokes had COVID-19. 40% of those were younger than 50 and had few to no stroke risk factors. So again, the takeaway is, one, these COVID patients are having strokes. It's a younger population that we're seeing as well. And then we're going to be seeing patients with aphasia, apraxia, dysarthria. And in addition to the cognitive deficits they already have with the COVID-19, they may have more cognitive deficits because of the stroke. So again, more to think about as far as therapy. So now we're going to just talk about possible cognitive treatment considerations with these patients. So again, we know they're confused and disoriented. So what can we do sort of immediately? So at this point, if we can provide them some external aids like a calendar to help with some orientation, at least in our rehab rooms and also throughout the hospital, they have these boards that have today's date. It usually has their therapy team and also the name of the hospital. So that will help with orientation for these patients. If possible, if we can acquire some family photos, I usually like to write the names of the family members on the back so that we could review with the patients and also work on orientation. Also talking to family members. So they're usually the people that give you the best ideas, or they tell you those little hints that you don't realize you're missing. Like, if they're bilingual, maybe they're definitely going to do better in Spanish. So you need to get the interpreter online, whatever it is, those family members usually give you some point to help you with. And then additionally, speech therapy, and we'll address all of those issues for memory, problem solving, reasoning, organization, orientation, and hopefully come up with some strategies that would help with this process. So now we're going to talk about some language considerations because of those stroke patients with COVID-19. And I actually put on ventilator patients with this slide as well, just because there's some overlap for sure. So number one, you want to establish communication with these patients. So giving them a communication board is probably a priority. We have to remember the ventilator, if they're don't have a speaking valve on or intubated, they can't speak. So we need to have them communicate with us one way or the other. And some of these aphasic patients also can't verbalize and possibly can point to pictures on a communication board to help express their basic needs and wants. And I'll show you an example of one in an upcoming slide. Another thing that we have to do is to establish a yes-no system. Again, this is a priority for these ventilator patients who can't talk. So we may have to come up with eye blinks where two blinks for yes and closing your eyes tight for no, or maybe looking up for yes or down for no. Head nods if possible, hand gestures, thumbs up for yes, down for no, or verbally for the aphasic patients if possible. And also remember to keep your questions short and simple and not open-ended. So if you're talking about pain and you're asking the patient, you may want to ask them, are you in pain? So it's a yes-no response versus where is your pain? Because these aphasic patients can't expand on those answers sometimes. And also the ventilator patients can't answer. So try to keep it yes, no, and simple. And then always face the patient while speaking. This is a bit more challenging because we're wearing masks now. So if you have a mask on and your face is turned, it's definitely going to make it more challenging. So definitely try to keep that in mind when working with these patients. So here is an example of a communication board specifically for COVID-19 patients. So you can definitely see how this is, I don't know, I was going to say, here they have a ventilator, a breathing tube. So these are very specific for like the COVID-19 population. We have protective equipment here. What's my COVID status? And then also up here, it's call my family. And you have to remember these patients are isolated. And so this is their only way to communicate with their family. So that's a very important picture at this point. If you look this website here, patientprovidercommunications.org, and you can get more free downloads for these communication boards. They have ones, this one has 24 pictures. There's some I think that have 12. There's also an alphabet board. So if a patient they can potentially spell out words, but that would be difficult, possibly for those aphasic patients. So also considering speech motor deficits that these stroke patients might be having that have COVID-19. So I'm just going to give you some strategies that maybe can help you with the patients when you're working with them. So if a patient presents with dysarthria, you want to ask the patient to sort of slow down and over-articulate their words. You want them to say every syllable in the word to kind of get their point across. Also, if possible, you want them to speak louder and also take a deep breath. This may be challenging, again, because of all these respiratory issues that the patients are having. So this may be a challenge, but if possible, try to use these strategies to help for these patients to get their needs, basic needs and wants across. So also we may be seeing patients with apraxia, and it sort of depends on the level of apraxia. If it's not as severe, maybe just asking the patient to slow down can possibly help with getting out what they want to say. If it's severe, you may want to go back to those, keeping your questions short and, you know, having it more of a yes, no, like we did for the aphasic patients. And then in severe cases, maybe using a communication board as well. Also, just another strategy possibly to help with both of these populations is that maybe trying to focus on the content words versus a whole sentence. So if they were trying to say, I need to use the bathroom, if they just focused on the word bathroom as the key word to get out their needs, that may help with, again, having them express their basic needs and wants. So now I'm gonna just talk about some respiratory deficits. I mean, obviously we're gonna see respiratory deficits and maybe some possible treatment plans with this. So we definitely know they're having reduced respiratory support, and these are some of the muscles that are responsible for breathing. And so we generally use breathing apparatus like the spirometer and the breather, and I'll go into that in greater detail. And we do, the speech therapists have a whole variety of respiratory exercises also to sort of, again, increase the respiratory support. So I actually had seen in a previous talk that this spirometer was, you know, potential questionable whether we should use it or not. I did a little bit of research just last night just to kind of double check, and I have seen other facilities using the spirometer. So I would potentially, you know, suggest, I don't know if it's aerolizing, you know, maybe it promotes a cough or something to that effect. But ultimately you could train your patient to do this independently. So I think this is definitely something to consider, and, you know, I'm sure there'll be more information as it goes along. But right now, I am going to say that you can use an incentive spirometer to help with their breathing and lung capacity. We generally give this to patients who've had surgery, again, to help like clear the lungs with fluid and such. So I don't know if you've seen this before, but you put the mouthpiece in your mouth, you inhale slowly and deeply through the mouthpiece to raise the sort of blue indicator here, which is the sort of blue piece that goes up. Once maximal inhalation is achieved, remove the mouthpiece and hold your breath for at least 3 seconds. If you can go longer, great. And then you just sort of exhale normally. Okay, but then this is for inspiration. We also, in our rehab department, use this device called the breather. I'm not promoting this, but I like it. This promotes respiratory muscle training for inspiratory and expiratory muscles, which is what I like. And you can also increase the resistance during both stages of the breathing process. So if you look here, there's an exhale, there's a 1 here, and it goes around to 5. And say for inhale, it goes up to 6. And basically you start at 1 and you try to find out if the patient, you put the blue piece in your mouth and breathe in and out. And you sort of find what's comfortable for the patient. You want them to have some effort while they're doing it. And as they're improving, and you know, this 1 is too easy, you can move it up to the next level. And again, that increases resistance. So all in all, I just feel like it's a good way to sort of help with the respiratory support. And also besides that, you're, you know, trying to get a strong cough, have a stronger voice. Those are some of the benefits for building up your respiratory support. And then as we were finally saying, again, there may be patients that have voice disorders. So due to intubation. So the problem we're facing right now is that ENT is not scoping these patients while they're COVID positive. At Mount Sinai, we're waiting again for 2 negative COVID swab tests before they start scoping. So we definitely, you know, as a speech therapist, usually that's sort of our first thing. There's a voice issue. Sometimes it's just, you know, maybe things are just, they're hoarse and their vocal folds are just swollen or red. So, if that's the case, we can kind of review vocal hygiene techniques such as vocal rest, increasing their water intake. But, if possible, we can get the ENT to scope these patients and then fully to diagnose them, we can, have a better understanding of what therapy to target. So if it's a patient that has paresis, then we can do some vocal fold exercises or approximation exercises to help strengthen that weak cord. And if it happens to be a paralysis, sometimes we'll do some trial therapies to see if there's any improvement. But sometimes you can get the strong cord to go over to meet the weak cord. But usually ENT will either do a Botox injection or medialization surgery, possibly to help with these patients. So that pretty much sums up our presentation today. And we wanted to open it up to questions.
All right, I think the screen sharing has to stop so we can, okay. Jacob?
Yes, thank you, Ms. Beth and Ms. Dana for a wonderful presentation. So I'm going to present some questions which is being asked in the live chat. And we have Ms. Srimati. The question is basically, could you highlight on your experience on pediatric COVID patients and example regression in language skills, which is observed in other post-viral encephalitis? I know that you have previously mentioned you're not working much with kids at present, but if at all, if you could translate your experience with kids in a different population, could you give your thoughts on it?
Yeah, I mean, again, we actually haven't had, we do have some COVID positive pediatrics in the hospital, but we have not had a consult on any of them so far. The only one we had was on a 19-year-old who's basically an adult anyway. But, a lot of the language therapy, I would say, would just be treated the same as if a patient had a language delay or had some sort of neurological condition where we're seeing regression, and just use the same skills where we're doing, play-based therapy to target those language skills to make sure that they're developing appropriately and also restoring whatever may have been lost. But I would be using the same strategies that we use normally if I were to see patients like that on the ped side.
All right, thank you. So there's another question from the same person, Ms. Srimati. So she's asking, can you share your thoughts on application of bedside ultrasound larynx as an indirect method for identifying laryngeal palsy?
We actually don't use a bedside laryngeal. This is the first I'm hearing about it. It's not a procedure that we use here at Sinai. So I'm sorry, I don't know the research behind it to speak to it, unfortunately.
All right. So there's another question from Ms. Pushpa. So what sort of cognitive linguistic screening do you use at ICU or acute settings? And does these cognitive deficits appear to be transient or more long-term?
We have sort of a screening test that we have put together, but it has different parts from various tests that are standardized, like the SCAT-B, the RIPA. Those are sort of some of the cognitive tests that we look at, but we have some other ones that we can look at as well. And the second question, the cognitive deficits, they're definitely, from the research, what I'm seeing is that it, especially those that were intubated, there definitely seems to be long-term cognitive deficits. So I think it's definitely something we're going to have to be working on for months to come.
Thank you. So another question. Yes, Dr. Resh.
So just wanted to mention to the audience that so those who are watching it on YouTube, there is a chat section on the right-hand side of your screen. I should have mentioned this in the beginning. So there's a chat section on the right-hand side of your screen, which is where you can enter your questions. So for those of you who are not familiar with the process, that's how you ask the questions. If you don't know how to figure that out, there is a number on the invitation that we've sent out. You can call that WhatsApp number and ask them how to access it. Thank you. Actually.
So another question by Ms. Shreya. Are there particular applications you use for teletherapy consultations and therapy?
Yeah, you mean like through what medium?
Apps. Yeah. What apps do you guys use?
Yeah, it's more just whatever whatever the patient's familiar with. FaceTime, WhatsApp. We weren't particular about what media we were using.
Okay. I think I'm assuming the reason they were asking this question is for privacy concerns, or is there any particular app that's more therapy oriented or sort of customized for therapy? Is there anything that you're familiar with?
I'm not right now. I know that WhatsApp has some greater privacy, but I don't know. I mean, and this was also before when we were, I don't know if you heard about it, but we were having some privacy issues with Zoom when we first rolled out, like, with education and everything. So at the time when we were doing these bedside visits, was the time where everyone was the video visits was the time when everyone was trying to figure out privacy considerations. And once that all got sorted out, we had already moved beyond that. So, we were kind of playing it by ear.
I know that the doctors here are using telehealth to, meet with their patients online. So I'm not sure if that's something that will develop down the road for, seeing patients in person, on the screen.
Got it.
Going to another question from Ms. Pushpa. So can you share how does the outpatient services have changed during this pandemic? Example, what type of cases that you have stopped seeing, or do you prioritize on seeing any patients during this pandemic?
Yeah, outpatient actually was closed down completely up until right now. We're beginning to consider what it will look like to reopen it, but we don't have any specific plans at the moment. I think it was Medicaid just finally approved to do telehealth visits, which is what's going to hopefully enable them to reopen in some capacity. But in terms of speech therapy specifically, all of our outpatient therapists were relocated to our acute side to help us, and that's the outpatient side was shut down for now.
So another question from Ms. Shobha. So she's thanking you for the wonderful informative presentation which you both have given. And the question is, would you know if the various mutations of the COVID-19 present similar cognitive deficits?
So that's also interesting, going back to our point about everything is still so new. We're still not even 100% sure if there are mutations or not. We've just been seeing generally that patients are presenting with the same cognitive and delirium and confusion, but I wouldn't say would be able to differentiate between different strains. I don't even know for sure if there are different strains or not. We don't know if people could be reinfected. Everything is still being researched and developed, and we're trying to keep up with all the new information, but something that we learned yesterday might be just proven tomorrow. It's all evolving.
Moving on to the next question from Srimati. So what are your advices on management of secretions or aerosol spread in tracheostomy patients in the ICU?
Yeah, so patients who require frequent suctioning, or actually not saying that they're not ready yet, because it does pose a greater risk for aerosolization. And another concept that has been talked about a lot in the research that we do have so far is that it's not just exposure, but it's the amount of exposure that you're getting. And remember that the highest viral load is in the nasopharynx, which is what we're dealing with, and that's where we're getting secretions from. So, going into these patients repeatedly and having to suction them all the time would increase the amount of exposure. So we want to give them strategies to help manage their secretions better, but they have to be able to participate at a certain level without requiring ongoing suctioning frequently throughout the visit, because that's going to place the clinicians at a very high risk.
Just adding to that, I would just put another question. So what is the weaning protocol do you follow in patients with tracheostomy in terms of using, you mentioned something about the speaking valve, and subsequently by capping, what is the duration or what is the protocol do you follow back there?
So I don't know if there's a specific duration on the doctor's side. For us, we use the speaking valve until the doctor determines that they're ready for capping. And then once they get to capping, the doctor takes over and will make the decision from there in terms of decannulation. But up until that point, we will be using the valve in therapy to move them ahead towards that point. And then part of the weaning process is also downsizing their trach. So some patients can make faster downsizes than others, but we really want to get them. And for some patients, it actually doesn't even affect them if they're on a Shiley aid. They, their swallow looks fine. They look totally as if they don't even have a trach at all when you assess them. But especially now where we don't have immediate access to objective assessment, the weaning protocol involves getting them down to a smaller and smaller trach while using the speaking valve, just to move them closer in the direction of capping.
Same thing in rehab, pretty much. We put the speaking valve on. They have to increase their, hopefully they can wear the speaking valve 24 hours. Eventually, the doctor will say, okay, let's start capping. And usually, it obviously depends, but sometimes that if they can tolerate capping 2 to 3 days, 24 hours without removal, then they talk about decannulating. But again, that's the doctor's decision.
We are looking for more questions now.
Yeah,
yes,
I have a couple. Sorry, Dr. Jacob, did you want to ask something?
Please go ahead.
So first is when, of course, we talked a lot about the precautions that you're taking and people must be taking when they're in this acute care setting, and oftentimes they are COVID positive at that time. Again, just to give you some overview about our healthcare setting, or the Indian healthcare setting, a lot of these patients, I suspect, will be treated in the outpatient or home setting. And I believe, I could be wrong here, I believe they have to have 2 COVID tests negative before they're being discharged from the hospital. Correct me if I'm wrong, Dr. Jacob. So in that setting, will the precautions change, or would you say, no, just, continue with whatever precautions that were taken in the ICU because of the unknowns? Or do we have more data on this?
So you're saying that the patients will have 2 COVID negative swabs and then go home?
In India.
Okay. Yeah. Okay. And then the speech therapist will be going into the patient's home to treat them at that point?
Yeah, most of these patients are either treated in the outpatient or home setting because they're very limited inpatient rehab setting in India. Very few.
So I would say, similar to what we're doing with MBS, again, because everything is so unknown, we don't know how long there's viral shedding exactly, and we don't know how far the distance needs to be. How far can if you cough on, is 6 feet really enough? We're seeing some evidence that's saying it's not. So I would say just similar to what we're doing with MBS, where we pretend that they're still COVID positive, even though they've gotten 2 negative swabs. And again, one of the other issues that we're facing is that some of these COVID tests we're getting false negatives and false positives. And same thing with the antibodies. We don't know if, 3 times the level of the antibodies really means that you had COVID, or is it because you had other versions of coronavirus, or the test was faulty, or, there's not enough research. So I would say to be cautious and try and protect the staff, that they should be putting on PPE as if the patient is COVID positive. It's kind of like, we assume that everyone has it and doesn't have it at the same time.
Got it. Yeah, I think that makes sense.
So I'm going over a few more questions now. There's another question from Srimati. So what are your suggestions to existing or pre-COVID tracheostomy patients on follow-up to prevent cross-spread of the infection?
I'm sorry, can you repeat that one more time?
What are your suggestions to existing pre-COVID tracheostomy patients to follow up to prevent cross-spread of infection?
So patients, just to clarify, patients who had a trach prior to COVID and now they're COVID positive?
I think they're not COVID, basically.
Non-COVID.
I think instead of the pre-COVID, they should have used the word, I think, non-COVID patients. So what are your suggestions to existing non-COVID tracheostomy patients who come for follow-up to prevent them from getting COVID?
I would say the same precautions that we're taking for everyone else, except for the fact that we need to remember that they have an open airway. So just like we need to cover our nose and our mouth, they need to protect their open airway when they're out and about, because that's another access point for exposure for them.
And how do we do that?
You can use a scarf loosely tied so that you're not occluding it so that they can actually breathe, but that you're protecting it. And, you know, again, unfortunately, we don't know how protective that is, but it's presumably better than the open air with virus.
Because you can put an N95 mask over this.
No, and it wouldn't be fit testing.
So that's tricky, yeah.
Definitely nothing too secure, because then they won't be able to breathe. So
That's a good question, but very tricky to answer.
So we have another question from Ms. Rekha. How do you work on improving the gag reflex if it is all affected in these patients?
We haven't really, that hasn't come up as a problem, but in general, we don't really focus so much on the gag because it doesn't really indicate dysphagia. You know, some patients have it, some don't. We don't test for it in our bedside eval. We don't really feel like there's research strong enough to support it. And during normal times, we're very heavily relying on objective assessments anyway. So we'd rather see what's there instead of guess what, you know, what the results are. But since that hasn't really been an issue during regular times for us, it hasn't really translated into a problem right now either.
Okay. So another question from Ms. Shreya. So when is it safe to move from ice chip protocol to other food substances if we are suspecting silent aspiration?
So for those patients, normally, if we were suspecting silent aspiration, we would move on to a fees, but we don't have that ability. If the patient really isn't tolerating ice chips, we probably wouldn't recommend anything beyond that for quite a bit of time and really just focus on secretion management and ice chips. You know, sometimes we'll treat ice chip protocol similar to the Fraser free water protocol, where it's okay if they aspirate a little bit as long as we're doing really rigorous oral care and trying to, you know, be working with PT and mobilizing them for pulmonary clearance, because our body can tolerate a small amount of aspiration on water specifically. The issue is when bacteria gets into the lungs with it, that can create a pneumonia. So, you know, it's better to have that tiny amount of aspiration. The benefit outweighs the risk of muscle disuse atrophy and poor secretion management from not actually using the swallow. So we would rather have them taking the ice chips, but we can't progress beyond that if they're visibly having a ton of trouble with it.
I mean, and then I think if they do test COVID negative twice within that 24-hour period, eventually you could bring them down to modified barium swallow and, you know, reassess it that way as well and see what's going on.
Thank you. So another question from Ms. Srimati. So how is the neurological recovery pattern in COVID versus non-COVID large vessel occlusion from an SLP perspective?
Can you repeat that? I'm sorry. So
how is the neurological recovery pattern in COVID versus non-COVID large vessel occlusion from an speech and language pathologist perspective?
I think large vessel occlusion, they probably mean a stroke. COVID versus non-COVID stroke from an SLP perspective.
Oh, okay. I mean, I don't know if we've had enough experience yet and research in that. I can tell you that, you know, as far as like the confusion, delirium, you know, if that clears, then obviously everything else, you know, you can sort of focus just on that, on the stroke issues and such, but the delirium on top of the stroke makes it even much more challenging to work with this patient population. But again, I can't tell you, unfortunately, just yet what the differences are between, you know, COVID versus non-COVID at this point.
Yeah, I think theoretically, I think it makes sense. I agree. They're often have this post ICU delirium, and then on top of that, it's just stroke. It doesn't matter what's the etiology, it's a stroke. So stroke maybe combined with possible ICU delirium may present a little bit differently. Yeah, theoretically, I understand.
So we have another question from Mr. Balaji. So the question says that how to assess the level of affection in brain of COVID patients. So to understand the question, I think he's looking for some maybe cognition assessing tools in COVID patients? Maybe that might be the question, if I'm not wrong. Could you give us some inputs on what scales do you use for to assess cognition in patients?
As far as assessing them, again, we tend to just have some standardized tests, which is the SCAPI, which is, I think, the scales of cognitive abilities for traumatic brain injury, the RIPA, which is the Ross Information Processing Assessment. These are all sort of cognitive tests that we use. Like there's the Burns Inventory. These are all sort of different tests that have scales that you can kind of assess these patients with, to sort of see what level that they're at. If that's the question, I think if I fully answered the question.
Dr. Jacob, I think we'll just take one more question, and then the rest of the questions, if there are more questions, we will just present the questions to them in an email, and the speakers can respond to those questions, which we will then post in the chat.
So last question would be, so what's your thoughts on gag reflex being a precursor for starting the oral feeds?
For starting oral feeds?
Yes.
Yeah, so as I mentioned before, we don't actually rely on the gag reflex because we don't find that it's indicative of whether or not a patient can swallow. We rely very heavily on the 3 ounce at the bedside. During normal times, they're only being used on post-extubation patients. So when we go to a general medicine floor, it hasn't been completed. So, I, in particular, I'll use it as part of my process, and then I'll usually push more than that. But the gag reflex is not even usually part of my oral mechanism exam.
Because if you think about it, just remember your gag reflex, you're not usually gagging when you're eating and drinking. So I feel like it's such a reliable tool as well.
Thank you, Ms. Dana and Ms. Beth, for patiently answering all the questions.
Again, thank you both. Thank you, Dana, and thank you, Beth. There have been a lot of audience that have said thank you. And it's mixed among the questions, so I don't know so I might be missing the names. But there have been a lot of people that have been thanking you guys for this wonderful presentation. And again, I want to thank you from GH Rehabilitation for agreeing to participate in this talk and sharing your expertise and knowledge on this. And this is particularly important, I think, for 2 reasons. One, of course, your expertise, and not just theoretical expertise, but also practical expertise, because you are working in New York City with these patients. So first, we have to thank you for that, and then second, sharing this knowledge would certainly be extremely helpful, because we see that the number of cases are slowly getting worse and worse in India. Still, the curve has not been flattened, and I think there's definitely more to come. And there is no way around it. I think we're definitely going to be called upon to take care of these patients. And I think the more prepared we are, the better it will be, particularly because we have not been seeing the regular patients. Maybe there is nothing happening. Maybe the road traffic accidents have come down, or for all these other etiologies have gone down because not many people are traveling. So that definitely, you just cannot do without seeing COVID-19 patients. I think that, you just have to deal with that, and it's just better to be prepared. And that's the point that I'm trying to drive. And thank you for everybody that has helped JH Rehabilitation in organizing this talk. Sri Vidya in particular, I think she's done a wonderful job in organizing this seminar. And all the speakers, not just speakers from today. And I also would like to thank once again all the speakers that have agreed to participate, and the audience who joined us for this presentation. I would like to thank them as well. Thank you all.
Thank you.
Thanks. Thank you very much.